Thank you for having us. My name is Elvis Ondieki from Nation Media Group. Please start by introducing yourself, what you do, and the realities of cancer in Kenya today.
Many thanks to the Nation Media Group for helping Kenyans to learn more about cancer. My name is Dr. Abeid Athman. I'm the head of department, oncology department. I'm an clinical oncologist by profession. It's my pleasure having you here today. Welcome to Kenyatta University Teaching and Research Referral Hospital.
Thank you. Thank you so much. You said clinical oncologist.
Yes, clinical oncologist.
That means you deal with all kinds of cancer, not particularly prostate.
Yes. So to begin is like oncologists, they are of different types. We have like hematologists, which they deal with the blood malignancy and non-blood related disorders. Then we have medical oncologists who deal with the hematology and medical parts, the solid cancers. Then we have clinical oncologists who deal with combining medical and radiotherapy. So they combine together. Then we have dedicated radiation oncologists. So these are the different type of oncologists available in the world. Yeah, it depends on the where you practice, where you trained. So it defines who you're going to be.
So, from where you sit as a clinical oncologist, what are some of the trends you've observed?
Yeah, so generally the incidence of cancer in Kenya is going very, very high, very, very fast. And unfortunately, the trends of cancer we are seeing more incidence of young people being diagnosed with cancers, and this cut across all type of cancers. For example, we have the leading cancer in Kenya is breast cancer, followed by cervical cancer. Then we have prostate cancer as number 3. If you look at all these cancers, we have like more young people being diagnosed with cancers compared to what we see in Europe and in America. So it means like we are a unique population, or there's the trend, there are some factors which could be leading to these cancers, which is something we are still trying to study in the country to understand what is happening. Talking about prostate cancer, usually prostate cancer is considered the disease of the elderly people, elderly men. But in Kenya, we are seeing the incidence of prostate cancer. Generally, it is occurring like there's a significant amount of young male being diagnosed with prostate cancer. Overall, prostate cancer, it contributes to 21% of all cancers, 21%. So this is a very, very big number. And remember, it is the leading cancer in male in Kenya and in the world. Yeah, after lung cancer, like prostate cancer is the second in the world. In Kenya, in our country, prostate cancer is the main cancer occurring in male.
Any more figures you can share about prostate cancer in Kenya?
Okay, so I mentioned like usually the average age of most prostate cancer in the world will be at the age of 70 or 65 and above. But in Kenya, we are seeing the average age coming down all the way to the age of 55, around there to 60. This is the average age. Then we have a significant amount of male cancer patients coming at the age of 45. Yeah, so this is a very young age to be diagnosed with prostate cancer. Again, we have also like the main part of the prostate cancer patient. These are the patients being diagnosed at the age of 65 and above. They're still the majority, and this is how it is seen in the Western world. But their age is like a little bit higher, so we can say prostate cancer is being diagnosed in Kenya like a decade younger to compare to the rest of the world, and this is very, very worrying.
So, what are some of the misconceptions out there about prostate cancer, which you've had to dispel when you speak to your patients?
Most common, we hear people saying that having sexual intercourse, if you like having sexual intercourse, you can have prostate cancer. We understand there is no connection to that. Then some people think if you have prostate cancer or any other cancer, you can infect the other person. Some people believe like cancers or in general, it only occurs in the old age. We have already said and stated in our data like prostate cancer can also occur in young people. Then the biggest elephant in the house, people think when you have cancer, it is like a death sentence. So I think these are the wrong concept we are having in our community, and we need to change these misconceptions. So we know that cancer can occur at any age, although it is more common in the elderly, it can occur in young age. Number 2, cancer cannot be passed from one person to another, like infection, like having like eating food, having sexual intercourse with somebody having cancer or prostate cancer cannot infect you. So it doesn't. However, we know that sometimes it could be hereditary. It can be running inside the family. Like this one is, we know it's a fact. But me and you, like now we're having having this conversation, Elvis, like it doesn't mean like you're going to have prostate cancer. No, it doesn't spread from one person to another.
Take us down there. Take us down to this beast we're calling a prostate. Describe it to us and tell us why it tends to get swollen sometimes and sick at other times.
So prostate is a gland which is located in the pelvis, that is in the lower part of our body, the hip region. So in the pelvis, this is where prostate is connected. And the prostate, it is part of the urogenital system where the urine is forming the kidney, then there are tubes coming all down through the ureters, then they go to the bladder, then passing through the prostate, like what we call the urethra, then the urethra passes all the way coming out in terms of to the penis, and somebody is supposed to urinate. So that so only male have prostate gland. So male prostate, the prostate gland, it is used mainly like both in the male activities, like to modify the sperms to make sure like they're fertile enough for somebody to be having to have children. So there is secrete some enzymes there, and also it is a passage for the urine. So this is the main function of the prostate gland. But we know that with aging, the prostate activity keep on reducing, becoming less and less. So because of this, sometimes it can have a compensatory mechanism. We can see the prostate wants to work as how it used to be very young. So this prostate start enlarging, becoming bigger and bigger and bigger. This is a condition we call prostate enlargement. Then the prostate enlargement, because remember you are becoming enlarging, and remember in between in the central, like there's a canal which is passing. As you enlarge, you are squeezing the canal, that is the urethra, making it very smaller. Because of this squeezing of the urethra, so we can see male, they're coming with the urinary symptom. For example, at a very young age, the urinary stream can jump very far, but because of the narrowing of the path become very weak. Then after that, you can see the patient cannot be able to have like some good erections in some male. So those are the things which we see like in the most common. So the most common symptoms we see like a urinary system symptoms are like the weak stream. Sometimes you can see like having common infections in this male patient because of the enlargement. This is one part of the disease which can occur in the prostate. The other part, because we know of the errors occurring in the genes, which is controlling the growth, it can lead to prostate cancer. So now cancer, it means there's an error like in the prostate doing its in all activities. Now some part of usually in our body, like we have what we call the body has mechanism to remove any error, like in the factory. When they manufacture, like they see there's any error, the body is trying to correct. So if this error is not able to be corrected early enough by our body, by the genes, like as we have some genes which we call them pre-cancer, like procalcitonin, and the other one like an inhibitor. So if they usually are balanced in our body, so when this balance is lost, then it means like it is leading into cancer because the growth is not regulated. Because of this unregulated growth, now we call it cancer. And when we say cancer, when it has the potential of this growth leaving the prostate gland to go everywhere to spread to other parts of the body, now we term it like a prostate cancer. Sometime we can have male coming like with benign prostate hyperplasia. So usually like a benign prostate hyperplasia is the enlargement of the prostate. They go to the urologist. Usually they are seen with the urologist. When they go to this urologist, like they see like there are no signs of cancer. So usually they take the PSA. Sometimes the PSA is very normal, like less than 4, even sometimes less than 3. Because of this low level, they are being operated as a more common procedure. Like you remember the channel was narrowed. Now you want to enlarge. So we do a simple surgery where a camera goes through the urethra, through the penis, all the way to prostate, to go and cause rechanneling, what we call TURBT, which is done. And then this one, it creates the channel, so it make the channel become big. So usually any tissue taken from the body, it has to be measured to confirm this was indeed an enlargement. We are seeing like there's a trend of patients coming with benign prostate hyperplasia or enlargement of the prostate. When it is rechanneled, when it is taken to the lab, it's coming like in cancer. We are seeing this trend is coming very, very high. So I think we have to be very careful. Sometimes even if the PSA is very low, the patient who are doing with having enlargement of the prostate, for those undergoing rechanneling, we need to ensure that we take this the material removed from the prostate for inspection to confirm this is cancer or not. So I think this is very important for us.
So related to that, you can speak to the early warning signs, early symptoms of cancer. Now, of course, swelling will be
Yes.
there, but what are the early signs of cancer?
So the symptoms sometimes could be very vague. They are not like the classic symptoms we can say these are prostate cancer, because you remember I told you like there's the prostate part. So depending on which part of the prostate the cancer has invaded. So let's say if it has invaded where it is near the urethra, or it is coming together with the enlargement of the prostate. So this one they can come with the typical signs of the urinary obstructions. So you can see like this patient, either they come with weak urinary symptom, sometimes even incontinence, like they cannot urinate, they cannot go to urine. So these are the most common signs of early prostate cancer: urinary incontinence, weak stream. So there's an overlap between enlargement of the prostate and also the prostate cancer itself. So it can be very difficult sometimes to differentiate, and that's why we need to go and do what we call screening. And the best tool, which it has been validated in many, many studies, like PSA is the best screening tool. Let me come back to screening. To the symptoms. So as the cancer grows, remember it is keep on invading the organs which surround it. So what it can do, it can either go to the bladder. So sometimes patient can go to like coming with a bladder, like a bladder in the urine, blood in urine. So this could be one of the symptoms. The other way, remember, behind the prostate, also down there, we have what we call the rectum, where the stool is passing. So sometimes we can have patients presenting with the symptoms like they're having difficulties in passing stool. So we can say this among like it means the prostate cancer it has now left the prostate itself, going into the surrounding tissues. Then the most common site where the prostate cancer it can spread usually is the bone. The prostate loves bone. So yeah, so majority of our patients, the first symptoms we are seeing is like they're coming with back pains or pain in the bones. So when you do like, so this patient, you see like they're being treated for like bone pain. We can attribute it to old age. Remember, I told you prostate cancer is the disease of mainly of the elderly. So you can be going to the clinic or just maybe buying like over the counter like painkillers. We are seeing it's not improving. But once you come and do your PSA, you see like, boom, the PSA is more than 100, 200, 300, or even 1,000. So the most early signs are seeing here, like in most of our patients, patients coming with bone pain. So we need to tell our people like we should never ignore bone pain in male who are more than 45. Any bone pain occurring in male more than the age of 45, we need to investigate why it is happening, and we need to do like PSA. So this, I think, is the very devastating. Then after that, as the cancer continue growing, it can go all the way to block the canal of the spinal canal. So once it blocks the spinal canal, depending on the level which is affected, different signs and symptoms can occur. For example, this patient is coming to you for the first sign, cannot walk. This patient was okay, just suddenly woke up like I cannot walk, or suddenly a patient woke up has urinary incontinence. Suddenly this patient come with a stool incontinence. So you cannot control the urine coming out. It's saying like I cannot control my urine. You cannot control your stool. You cannot feel your legs. So inability to walk. So all these are like they are already late signs. It means the cancer spread all the way from the bones going to the spinal canal, causing stenosis through what we call cord compression. So all these we need to be telling our people to pay attention. Like not only because sometimes somebody can tell you, I went to the toilet, I fell. Yes, it could be maybe this is a trigger. It is worsening what we're already having. Remember, it is going to the bone. So when you fall down, it can lead to fracture to any of the bone sites. So we need to be very, very careful and with the bone signs.
Yeah, you've spoken much about PSA. Please
Yes.
explain what it means and
Yeah, so
how it
PSA
operates.
is a prostate-specific antigen. This is a substance which is produced by prostate. But we have to understand the PSA is not like, we know it is specific for prostate, but we know that it's not specific for prostate cancer only inside the prostate. For example, somebody after having sexual intercourse, the PSA could go high. Remember, behind that, you could be stimulating the prostate. So the prostate, the PSA can become high just by having sexual intercourse. So when you go to the hospital and they see the PSA is high, this is one of the things we need to be asked, when was the last time you had sexual intercourse? Because we know it can raise. Again, for patient having constipation, the PSA can go very high. For patients having urinary infections, urinary tract infection, especially the lower urinary tract infection, again, they'll come with a high PSA. So these are the things we need to consider when we are talking about PSA level. Like it is not like when you come with the prostate which PSA which is very high, is already like confirmed is cancer. Of course, there are levels. For example, when it comes like more than like 7, 8, 9, 10. Sometimes even 10, it cannot be specific. But if you see like PSA already like 15 and above, like the probability of you having prostate cancer is very high. But now we are seeing the level of PSA from 3, 4, 5, 6, 7, 8, 9. There, especially after having sexual intercourse, urinary tract infection. So usually we treat the underlying disease, or we give this patient like some time to go and relax, then come back to us to the clinic after a period. Then we measure again. If we say now it is high, it is elevated, then we can confirm there's elevation of PSA.
You see a hospital organizing a clinic, a test clinic. More often than not, they are welcoming men to do PSA tests.
Yes.
Is that a good starting point towards diagnosing?
Thank you. So we have what we call prostate cancer screening. So prostate cancer screening can be mass population or can be targeted screening. Mm-hmm. So the mass population, we have seen that it used to be done in the United States through the USPTF program, which started many years in 70s. Because of this screening, mass screening, initially they used to get like prostate cancer at a very late stage. Once they started doing like mass screening for everyone, which was the age of 50 and above, they started getting prostate cancer at very early age. Then it means there were more surgeries being done to this patient. So they came and look at it they saw that they are over-treating the patient, because we know that prostate cancer is a very slow-growing disease. For example, if it starts manifesting, it must manifest before it becomes like an overt disease. It will take like 10 to even 20 years before it can become like something which we're now very clear, like giving symptoms and everything. So prostate cancer is a slow growing disease. So because of this, now we classify these patients into high risk population and into low risk population and average risk population. So high risk population, usually these are patients who have like an history of first of all, in the USPTF study, they classify high-risk patients as any Black American patient. So in Africa here, we are all Africans. So it means we are already like high-risk people. Okay, that's number one. Number two, these are the patients who had a strong family of prostate cancer. Like we have like 2, 3 members having prostate cancer. This is very high risk. Then we have somebody in the family diagnosed with prostate cancer at a very, very young age. At a very young age, we mean like age 45 and below, or sometimes we go all the way to 40 years old. Okay, this is number one. Now, the other thing we see, like these are patients having germline mutation. We know that some cancers, they are being passed in the lineage. That we call them germline mutations. So there's the error in the germline, like where the gene is created, like passing, it can be passed from one family member to another. So usually these are the BRCA mutations. We look at the ATM mutation. We look at the CHEK mutations. Sometimes even some other part mutation. We came to realize anybody with a family history of this germline mutation. Initially, the BRCA mutation and other germline mutation, we used to think they are only occurring in the breast cancer patient. But now we know that there's a connection. So it can be like the BRCA mutations, it can occur in breast cancer, it can occur in the prostate cancer, it can occur in pancreatic cancer, and many other cancer. So if we have a family member who has been confirmed with the germline mutation, it means it's putting you at a very, very high risk. So this group of population, we can go all the way, sometime up to 40 years, to start screening of prostate cancer with PSA. Then even the level of PSA, we want it in this high risk to be less than like a 3, because we know anything 3 could be raised like an alarming patient. So this patient, we can be following them 1 to 2 years to do PSA. Then we have the low risk. These are the patients who don't have any family history of prostate cancer, like they don't belong on this patient. So depending on the countries, some people, they say we can start doing PSA at the age of 45, but some, they are going all the way to the age of 50, 55. So it depends from country to country guidelines. So in Kenya, we can say, according to the National Cancer Control Program, at the age of 45, it is somehow like considered we can start doing our PSA screening. So then, because if you are low risk, then you can be repeating this step like after every 2 to 3 years. Sometimes we go even extend behind it. Like we have the German study, we call it the Probe study. In the Probe study, they were looking, these are the young patients who are coming at the age of 45 years. Yeah. Then they were looking at doing PSA level. These are the patients who had normal PSA level. By normal, they considered at a PSA level of 1.5. Remember, up to 4 is considered normal. So at 1.5, then they repeated, they followed up this patient and looking at the PSA at 5 years later. The incidence of cancer was extremely low, less than 3%. So now they are trying to discourage doing in this population. Remember, these are white population, and here we have like high risk African population. So some of this study, we have to be very careful when we are studying them. We have to put them into context. At least from the America, they use PHF. We know they have the Black American population, and we are Africans. We are not typical like Africa. So I think for me, I will advocate more. We follow the American in terms of guidelines because of the African population. And remember, they have done these studies extensively.
So that man who hears about maybe prostate cancer screening at small XX tomorrow, encourage they should go. Because some people think when I'm going for prostate cancer, they are gonna do those intrusive things on me and all that.
Yes.
There's a lot of fake news, if you may, about prostate cancer screening.
Yeah, so part of the prostate cancer screening, but it is not routinely done. Initially, it used to be done for most patients, is what we call digital rectal examination. Digital, it means fingers. Rectal means the rectum. Where the stool is coming for. It means your doctor will put the hands beside where the stool is coming towards the rectum to confirm. So what they do with this rectum, once they go inside there, they are like to see how is the prostate. So usually in prostate cancer, the prostate is very firm and rough and coarse. So this is possible to see if the cancer is occurring on the periphery of the prostate cancer, so you can clearly pick it, especially if your patient is having the PSA level which is not suggestive, so you could combine it. But nowadays we don't routinely do it. But for patients who coming with very high PSA already, so the digital rectal examination may not be needed there. So the digital rectal examination, it will depend with your doctor whether it's going to do it or not. So we don't routinely do a digital rectal examination, but we routinely do more of the PSA. Sometimes we can even add an ultrasound to confirm, especially for the patients with having a borderline PSA and everything. You can even request for a simple ultrasound. Sometimes it can help you to see if this is just the typical enlargement or even suggestive of cancer. Yeah, so this is when we talk about screening. But when we come to diagnostic, so for patients who are having high elevated PSA levels, it means now we have to take the next stage to confirm is this cancer or not. So usually we do the standard of tool we start with is a multi-parametric MRI. So this is MRI looking at different phases to confirm it is having very high sensitivity to confirm this is prostate cancer. So we start with the multi-parametric MRI after we see the PSA level is high. After doing this, it helps in two ways. Number one, it can help you to even identify which part of the prostate. Remember, prostate itself, it has lobes. Yes, so it can be periphery, it can be a central, depending on the location, anterior, posterior. So making it very easy for the person who is coming to take a sample, what we call biopsy. So after MRI, the next step we go is biopsy. So in the biopsy, again, we prefer image-guided biopsy, and the best tool for image guiding is a guidance with the MRI. If in the absence of MRI, we can use the ultrasound. But sometimes, because of lack of resources and in peripheries, what we used to do, blind biopsy, we don't encourage this anymore. So we prefer image-guided. The least we can say should be at least ultrasound-guided image. Otherwise, the standard is using the MRI. After we confirm all this with the biopsy, now we already have cancer. Then again, we come and look at the Gleason score. So it give us the grading of the cancer. Is it proliferating very fast? Is it the cancer is slow growing, high growing? So we grade it based on the PSA, when it is very low, when it is average and high. For the patients who are very low and the cancer is very small, then we know the treatment is different. For the patients who are having high grade, and the cancer is very big, the treatment is very high. So we put them into risk category. So based on the risk category, then we know what we can do. Then after that, we have to screen the whole body. Remember, we said that prostate cancer has the potential going to the bone very fast. So we have what we call conventional images. Then we have the modern imaging. So the modern imaging is the PET CT scan. So PET CT scan, even the PET CT scan, we have a dedicated PET CT scan, which is only made for prostate cancer. We call PSMA PET scan. So even when you're requesting for PET scan, you have to identify and you have to specify which kind of PET scan, because this, remember, your patient is having prostate cancer. So we know that like there's a normal distribution of the PSA in our body, like when the PSMA it is injected. So there's a normal part. So this one, it will go throughout your body and identify any part where the cancer has moved. Either it is localized in the prostate or it has moved to other part of the body. Okay, so this PSMA, it is very high sensitive. So nowadays we advocate for, if possible, like all patients to undergo this one, especially those with advanced disease. In early, we might use it depending on the doctor, what the CT scan is suggestive, like at the early stage. So I think with this, I will move to the management. So prostate cancer, which are localized in the prostate and very small, what we call the T1, has not spread even to the seminal vesicles. Seminal vesicles, they are just behind the prostate and has not gone into the capsule. So most of the time, this kind of patients, they can undergo what we call surgery. So surgery is the best treatment. And we know that for patients who undergo surgery, they live extremely long. They can live up to 20, even 40, or even 50 years without the disease recurring. Remember, prostate cancer is a very slow growing disease. So depending on the age of the patient, we are going to see, are you going to have benefit? So we again classify you based on the disease itself and your age. We see, let's say if your lifespan is more than 20 years, we might think of treating you. We see your lifespan is less 15 years, so now we can talk to you whether to treat it. But then we see that your lifespan is like 5 to 10 years, depending on the early stage. So you coming with prostate cancer in early stage, so your doctor will look at this category depending on your age, how much time in life you have, based on the Gleason score, like is it low risk, the size of the tumor, and your age and the preference. So based on this, one of the treatment option is not to treat the patient. Then the other option we have in early prostate cancer, we can go for surgery. Then the other one, we can go give the patient brachytherapy. So brachytherapy is a type of contact radiotherapy, where the urologist will come and include and put some particles inside your prostate. Then we are going to radiate. So it's a localized radiotherapy. Brachy means close. So it's a contact type of radiation therapy. So these are also patients who are going to benefit. So the choice is spoiled when it comes to early prostate cancer. Then to some patients who the tumor is slightly bigger, we can think of now giving the external beam radiotherapy. So in the external beam radiotherapy itself, now we can have different type of hypofractionation. Let me now move to mainly radiotherapy. So once the cancer increases in size, it has gone maybe in both lobes, even invading the seminal vesicles, and even but it is still local, still not metastatic. Yeah. So this patient, most of the time, operation is not possible. Maybe even the patient doesn't want to do operation. So we usually send them for radiotherapy, and then we do what we call external beam radiotherapy. So where the external beam radiotherapy we treat either using the linear accelerator, the image on the first one, that is a linear accelerator, or we can even use the cyber knife. So depending on the type of fractionation or how fit or how small or how big your cancer is. For using the external beam radiotherapy, the treatment can last around 6.5 weeks. 6.5 weeks, the whole fractionation. Then, if the cancer is very small and we want to shorten the treatment, now we can even shorten the treatment to less than 1 month. Sometimes even just a few, like 1 week or 2 weeks, like 1.5 weeks. We can use that with using the cyber knife, what we call stereotactic body radiotherapy, using the cyber knife. Even sometimes some of the linear accelerator, like the LINAC is called linear accelerator. We also call what we call hypofractionation radiotherapy. You're reducing the treatment time from 6.5 weeks, sometimes even to 5 or even 4 weeks using the linear accelerator. So all these you need to discuss on the context of the patient, what can afford, the preference, and the lifespan of this particular patient. I think there's one thing I forgot to mention, and this is very important. Remember, this prostate cancer, it's a disease which is being pushed by testosterone, which is being produced there by the testosterone. So one of the main treatment of prostate cancer, it means we have to block this testosterone being produced. So by blocking testosterone, all these methods, remember I mentioned, like external beam radiotherapy, surgery, sometimes we combine them. So depending on the high risk, it depends. Or it depends. You can be given like we block testosterone, like the duration is different. Sometimes we even remove this testosterone. Testosterone can be removed by two ways: either by surgery, where the testes are being removed, or it can be removed by chemical, castration, where we inject the injection in the anterior part of your abdomen. Remember, this treatment, it goes all the way to your brain. It sends information to your testes. Please stop producing testosterone, that we call chemical castration. So chemical castration is the most acceptable with most men, because no men would like to lose their testes. So we are seeing it
And it's
become.
permanent though.
It is reversible. Remember, it is the injection you are giving. So once you stop the injection, it can be reversed. Okay, so this is reversible. But the one when you remove your testes, it is not reversible. So that's why we need to give you continuous injection every 3 months to ensure that we are blocking your testosterone. So in some patients, this could be the only treatment we could give, especially those coming very early with disease. We can also just decide. Remember, I said we just don't do any treatment. We can also consider this type of treatment. So there are many factors. So management of prostate cancer is very extensive. We have to do what the patient wants and what is good and what the patient can afford. So for patient cannot afford, we sometimes ask them if they would like to be castrated surgically. So, but the good thing nowadays, the social health insurance fund is paying for most of this treatment. So most men, they don't need to worry like going for injection. Maybe sometimes patients don't want to go like frequent to hospital. So we'll give them this option. So let me go back to the systemic blockage. So in the systemic treatment, again, depending on if the cancer spread now has become metastatic, now we have what we call combination of therapies. So we block the hormones with the gonadotropin releasing hormone antagonist. That is the injection I mentioned. Then together we combine with chemotherapy to bring down the PSA levels very fast and to control the disease. This is one option. Then we have new modern drugs which block androgen receptor blocker. Remember, the testosterone is being manufactured by androgen. So there are drugs which we are going to block this androgen synthesizing. So we are also blocking we are double blocking with the testosterone blockage directly. Also, like receptors there, we block the receptor so that even if something is produced, it cannot act on this receptor. We have very wonderful drugs in the market. For example, the abiraterone, the apalutamide, and everything. These are the most common used drugs. So sometimes we can give you the an antagonist together with the example of abiraterone, or we can combine together with the chemotherapy, depending on the stage.
Yeah, you can tell us about the latest trends in the treatment and management of prostate cancer.
Okay, so what we have now, really coming very hot in terms of cancer treatment, is the shortening of the treatment of the cancer treatment. They want to shorten the treatment, as I mentioned, to the ultra hypofractionation, like giving very high dose of radiotherapy in a very short period. So these studies were presented in the American Society of Radiation Oncology in America last month. They were trying to look at giving the conventional way of giving radiotherapy to 6.5 weeks, to shorten it to like a month or less through the SBRT. So this study showed us, at least now it is more reassuring, like if you're giving like a very high dose for a very short period, giving it in the conventional way, in terms of survival, it is the same. In terms of side effects, like there's no increase in terms of side effects, and long-term side effects, they're all appearing the same compared to conventional. So now we have more reassuring data showing that SBRT, or stereotactic body radiotherapy, should be the way to go. And in Kenya, we are lucky, like in our institution here, we have it available at the Kenyatta University Referral Hospital. The other one, now people are moving big in using the radioligand. These are some types of radionuclide which are injected into your body, in your blood. They go. It's a form of radiation, by the way. So it is injected in your blood. It's a substance which is we are using at the moment. It's lutetium PSMA. So lutetium, and they are of different type. So once they inject into your blood, it goes and kill around all the cancer. So it is becoming big. This data was presented in the European Society of Medical Oncology. It was also presented in the American Society of Clinical Oncology, and also it was presented in the American Society of Radiation Oncology in the PSMA-4 study, which was conducted in Europe and America. We also have the same study, using a different one, which was conducted, being led by the French team. They came to realize when they are giving this radioligand, there were very high incidence of fracture. So because of that reading of high incidence of fracture, so they started adding a bone protective agent. And then especially the French study, when they started adding the bone protective agent, the incidence of fracture became less and less. So now we have more confidence this kind of substance radioligand can really be a game changer in our setup. Initially, it used to be given mainly to metastatic patients. That means the cancer has spread all over. So now it is moving towards the early prostate cancer. So the field is enlarging, it is expanding very fast, and we are seeing improving survival outcomes in prostate cancer. What I would like to bring to attention to our population, or to our viewers and listeners, is prostate cancer is a very growing disease. So we need to detect it. We need to treat it. For patients who are treated, they live extremely long life. So this understanding, when you're diagnosed with cancer, it's like a death sentence. We need to remove it from our minds. Anybody with prostate cancer can be treated and live extremely long life. Some might even die due to other cause, because now they're living very long. Especially, remember, this is mainly of the old patient. So they may end up dying because of heart disease and many other causes, not specifically dying because of prostate cancer. And this trend, we are seeing it is increasing in the United States of America. So we need to reassure our population prostate cancer is curable. Even if it comes very late, it's manageable. Patient will have very good quality of life, and he can enjoy his life. We have had patients coming here, they cannot even walk because the disease has spread all over the bone. With the modern treatment, with the combination of abiraterone, chemotherapy, the generation antagonist, we are seeing now the survival outcome is doing extremely well. Remember, it is not only about survival outcome, but the quality of life. These patients are enjoying their life. They are going back into their life, doing walking and everything. So we want to tell our population prostate cancer is very manageable, whether it comes at very early stage or even in metastatic disease, which is has spread to other parts of the body.
You spoke about testosterone. So does that mean prostate cancer can render you a eunuch, can render you less manly? See, you've lost those two organs.
Okay, yeah. So remember, part of treatment of the prostate cancer, we want to block testosterone. So some of the side effects, the libido might become very low. Actually, I would like to inform you that we are going to have the Kenya International Cancer Conference, which is happening in Kisumu next week from 21st to 23rd. This topic of male of sexual activities with the side effect of treatment of prostate cancer, we have a specific speaker we have invited to come to talk specific about it. So we are going to highlight in a more wide way, and we are going to give solutions how we can overcome it. But generally, it reduces the libido, but it is manageable and we can take care of it. So there's nothing to worry about it. So I would like to invite the media and the general population and everyone listening to us across Kenya to come to Kisumu to learn more about management of the sexual disturbances because of prostate cancer treatment.
A man at 50 with zero testosterone in the body, or minimum, does that bring side effects? Maybe the boobs start coming out?
So sometimes it can lead to gynecomastia. Gynecomastia, it means the boobs are now, the breasts are becoming big, to become like those of women. Is a condition we call gynecomastia. It can lead to these kind of conditions. But we know that gynecomastia itself, it doesn't occur to everyone. But it can, again, even if it is there and it's bothering the patient, we know we can manage it either with radiotherapy or with treatment and many types of manipulation. So it is something which is very manageable. we can take care of it. So there's nothing to worry about it. But it is one of the side effects we expect together with the increase in men libido.
Okay. You
Yeah.
spoke about lifespan. So what age do you work on? Do you work with 100? Do you work with 80? For example, if you get my cancer at 75, you say
Yeah,
I have
so if
20.
you come at the age of at 75, but you're extremely active, like you look at somebody who is at 45 years, what I would like here to demystify, in oncology treatment or in cancer treatment, we don't look at biological age. I mean, we don't look at the chronological age. We look at the biological age. For example, somebody coming at the age of 70 or 75 years, but he's extremely fit. He's running, walking, and everything. So this is biological age. We can say it is coming all the way to 45. Then we have another person who is 45 or 50 years, but looking somebody like who is 75 or 80. So there's a discordance between biological age and chronological age. I know we are paying more attention to the chronological age, but biological age matters. That's why I'm saying like treatment will be decided like mainly your chronological age together with the biological age, how fit are you, and how you are willing to be treated. So patients who are like 75 and above, we can decide to give them less aggressive treatment if we really want to give them treatment. Yeah, and there are many ways we can manipulate, and we discuss from one patient to another. So in oncology nowadays we call what we call personalized medicine. So there's no one size fit all. You come as if we have a cancer patient, will be treated according to you. So sometimes people may be wondering, like you're at the age of 75 and this other person is also at the age of 75, the treatment is totally different. So here we look at the risk factors, the type, how aggressive this cancer is, your biological age, your chronological age, and how willing you are to be treated. Then we personalize that treatment for you as a person. So we don't treat like one size fits all at the moment nowadays. We have changed about that. The risk factors, usually we classify them into modifiable and non-modifiable. Modifiable, it means like there's something you can do about it. Then non-modifiable, there are the risk factors which we know we cannot do anything about it. Number one, being a male, we know that it's a high risk. It like put you like a chance of getting prostate cancer being a male. Just like in women, being a woman is predisposing you to having breast cancer. Then we say like a genetic predisposition, like those women having, men or having like family risk of genetic changes like BRCA mutation, check mutation, everything. Then being an Black African American, it puts you at a very high risk. But these are the things we cannot change because we are born with them. Then the old age itself, you cannot change that because we know we must age. So is a non-modifiable factor. So we know aging, the more age you have, the higher probability of you getting cancer. One of the things which we can do to change, and we know that the use of cigarette smoking, like alcohol intake, like obesity, these are some of the risks which are modifiable. So we advise men to quit smoking, those taking a lot of alcohol to reduce and even stop taking alcohol because we know they contribute into causing cancers. Then obesity is a very big problem, not only to prostate cancer, but it can lead to any cancers. So we advocate people to check on their diet, reduce like saturated fatty, like food with less fat. Then for more like doing exercise. These are the things which you can modify in changing you becoming obesity, and in that matter, you're reducing the chance of you getting prostate cancer. I think obesity is a big problem which we have underestimated. In the country, we need to really look into it. A study which was conducted in Nyeri County Referral Hospital, where they're looking at a 5-year study, the prevalence and the predictors of cancer. We can see that in their population of the Nyeri, like this patient, the average age of the cancer diagnosis was at the age of 70. And none was at the age below of 40, but they had some few patients coming below this. And this one is showing again the distribution of prostate cancer among our population. Like it is not like uniform. From my own observation, from the coast regions, we are seeing prostate cancer men being diagnosed much younger, and you know that prostate cancer diagnosed at younger age, like it is more aggressive, it leads to poor outcomes, and that's why sometimes we even advocate for patients who have like family history to go all the way towards the age of 40. Yeah. Then we have another study like which was looking like the uptake, how readily men accept the taking of doing prostate cancer screening. This was a study which was conducted at Mount Kenya University, They look at this study, the prevalence of how the men they interviewed, they had conducted screening, it was very, very, very low at 5%. It means like our men, they have not readily accepted the uptake of prostate cancer screening. I think based on this study, we need to change as men in Kenya, because the uptake of prostate cancer screening, it is extremely low. And it was mainly associated, for those who had already they had done like a prostate cancer screening, mostly there were people who are educated, they're coming from high socioeconomic status. So that means people coming from low socioeconomic status, the probability of them going for cancer screening is very low. And we understand, because of the socioeconomic, will they think about putting food into their mouth or sending this man for screening? They feel like this cancer should be dealt with when we come to it. So I think this is like the data we are having coming out, like our screening is low in our countries, and the distribution of prostate cancer according to age also varies from one county to other in the country.
Thank you. So, which actually brings me to the other question here.
Yeah.
People out there say our grandfathers never used to have cancer and all that. Is it possible it was totally out of the question, or people actually had cancer but there are no machines to test?
Yeah, actually, this is a very interesting question. Remember, we said prostate cancer is the disease of the old age. We need to ask ourselves how many old people we have, or we used to have back then at the home. These patients were bedridden, they could not walk, or they were walking with a stick, always complaining of back pain, attributing to old age. Who knows all these patients, they are prostate cancer. Remember, prostate cancer is a very slow growing disease. So if we go out there, we do PSA in these old patients or old people, I believe we can get up to 30 or 40% or even more. The PSA becoming extremely high, because we don't know this back pain. Because you even here in our institution, we are seeing more patients are coming with the main complaint as being back pain. So it means like in elderly, these cancers were there, but people are not going to the hospital for it to be diagnosed, because now people they're having their children who are more educated, they're more worried, like their parents, they cannot walk, they want to their social to be playing with their grandchildren. So we are seeing more guka coming here, being brought by their children, and we are seeing the trend is going very, very high. We are diagnosing more elderly patients, especially those coming from Central Kenya. The age at which they are diagnosed, they are extremely high, like I can say 70 and above. Then those coming from this other part of the Kenya, we are seeing like they're coming from the age of 60, coming towards below. So I think it is giving us a picture. The prostate cancer, it is there even among the community, but not because we are not doing like a screening like other countries they are doing. Due to this, we could be having less incidence of prostate cancer.
Okay. So ukiona mzee anajikojolea, as they say,
Exactly.
don't stigmatize, maybe it's prostate cancer showing.
Right.
So the very final question I have, how does prostate cancer cause death? Because sometimes it leads to death. How does that progress into death?
So usually prostate cancer, as it goes, remember it is spreading. So spreading, it can spread in different ways. Number one, it blocks the urine from coming down. Yeah. So once it blocks the urine from coming down, it means there's a build-up of toxicities in the body. You see the amount of urea coming up, the creatinine coming up. So these, remember, they are toxics, which the body doesn't want them. So we might see like the old patient, they're coming confused, sometimes even convulsions. Sometimes they don't want to eat, they're weak. So as the amount of urea is building up, and we are not able to control it, even with all the intervention we have, because sometimes we can put a stent, sometimes we can put a nephrostomy tube. But as you go, even that, the kidneys, they are not able to handle all that, because the toxins, they are not being removed effective. So this is one they die through because of their kidney failures, or what we call renal failure. The other way it causes death is because of the cord compression. It compressed the cord. So depending on the level of cord compression, this one it will be affected. The patient will not be able to walk, and because of that, they may even develop clots in the body. So depending on the site, all this can lead to death. Number three, the other way of causing death, the cancer itself, it can spread all the way to the brain, and we are not able to control it. It can lead to death. And sometimes we have infection, which because of bedridden and everything, it can lead to infection. So all these, they contribute to death among the prostate cancer patients.